is the technique that most of us follow. So however, TRAB has its complications, early complications like leakage, hypotony, and late complications like leakage and infections. So in 1989, so because of these complications of TRAB, because you enter the chamber, so the chances of leakage and hypotony happens. In the 1990s, deep sclerectomy, Fyodorov introduced this deep sclerectomy technique, popularly known as the non-penetrating deep sclerectomy. And in 1999, Stegman introduced viscocanelostomy. So here a deep scleral flap is excised under a superficial flap. So it creates a scleral lake, and the aqueous actually percolates through a trabecular descemet's window. So this was all to prevent this healing process and to reduce the complications which was seen with trabeculectomy. But however, the intraocular pressure control was not as good as for a TRAB. Then canaloplasty also became popular for some time. So this is an extension of the viscocanelostomy procedure with the addition of a tenoproline suture, which was passed circumferentially 360 degree through the Schlemm's canal and tied with enough tension. This is to stretch the TRAB meshwork. Then the glaucoma drainage devices were being used. In fact, in the 1900s itself, so many techniques were tried where the horsehair, so in 1906 horsehair was tried, then suture materials. All these were to have a conduit between the antechamber and to the subconjunctival space. However, the first commercially available implant was the Molteno implant. And as you all know, the aqueous shunts could be valved or non-valved, and they vary in material size, shape, size. And the popular ones are Ahmed, Bawel, and the prototype of Bawel, the Indian indigenous device, the RD, which is very popular. And there are also Paul glaucoma implants, and then recently the non-valved part of the Ahmed, that is the Ahmed clear path, has also come up. And tube surgeries also do have their complications. Early ones are hypotony, shallow chamber, and late complications, again, hypotony, especially with the non-valved, and then motility disturbance and infection. So the surgical armamentarium for glaucoma includes the traditional trabeculectomy and the GDDs, then even the laser procedures, and the newer ones, the MIGS. So what is MIGS? It's the minimally invasive glaucoma surgery. This came up to reduce the complications. That is, they are supposed to have a high safety profile and with a shorter surgical time and a shorter recovery time. So broadly, based on which part is targeted, they can be divided into under trabecular outflow. We have the iStent, Hydrus, trabectome, GAT, bang, and Cahook braid. These procedures also come under this trabecular outflow group. Then for suprachoroidal, we have the iStent Supra and others. In subconjunctival, ab interno technique is a Zen, and ab externo, the PRESERFLO. And then there are also future MIGS devices, and then even this iWatch implant, which can be attached to any drainage device, and you can titrate the pressure. So if you compare all the glaucoma surgical procedures, trabeculectomy stands above, supersedes the others with a high intraocular pressure control of 50% at 5 years. Compared to the other procedures. So in summary, what I would like to say is the newer procedures are still evolving and are yet to replace TRAB as a gold standard for preservation of visual function in early and moderate glaucoma. But TRAB still remains the time-tested surgery for advanced glaucoma. Thank you.
Thank you, Dr. Subhashini. A wonderful presentation and a very good compilation of all the surgeries, but then trabeculectomy remains the gold standard. With this, we move on to another presentation by Adrian Braganza. That is the conversion of topical trabeculectomy, phacotrabeculectomy, step-by-step approach.
I would just like to add that the pediatric glaucoma surgeries have evolved over the years. Like goniotomy was first described by Barkan, then came trabeculotomy, then combined trabeculotomy with trabeculectomy, and now we have a 360-degree illuminated microcatheter assisted trabeculotomy.
Yes. Even the trabeculectomy has become a better because of the evolution of the mitomycin C and 5-fluorouracil. So we are getting good results even for our repeat traps, the where we are like thinking of using a valves. So always there is a debate whether to use tubes or to do trap with mitomycin C or any other associated things.
Good morning. Can I start? Yeah. I'm Dr. Adrian Braganza. At the outset, and this is my topic, it has to do with topical trabeculectomy associated with SICS and phaco. Can I have a show of hands of people who do this routinely? One. That's it? Okay. Yeah, okay. Either. Okay, I'll just start now. So this was my initial hesitation, but over the years I've overcome that, and I would like to share my experiences in the 6 minutes that I have. Okay. Yeah. So this is the content. The introduction. The authors Azuro and Blanco and Vicari about 15 years ago published their papers comparing peribulba with topical trabeculectomy, and found that there was absolutely a minimally different features between both of them. The need for topical anesthesia in phacotrabeculectomy or TRAP is to avoid the risks associated with peribulbar anesthesia, which is globe perforation, retrobulbar hemorrhage, etc., etc. In advanced glaucoma, topical anesthesia does not increase orbital pressure and avoids further optic nerve damage. Previous studies have shown that topical anesthesia is a safe and effective anesthetic method in trabeculectomy or phacotrabeculectomy. Patient selection, very important. A POAG patient with coexisting visually significant cataract who are cooperative and with the ability to fixate light, most important. Avoid patients with secondary and angle closure glaucoma, one-eyed patients, mental instability, and language barrier problem. Counseling, very important. The risk versus benefit evaluation has to be done by the surgeon himself. Clinical picture versus the surgeon's competence vis-a-vis a time factor, also very important. My standard is a soaked pledget with 4% xylocate. I do use a 4 suture for the superior rectus and intracameral lignocaine. This is the chair time, also very important, and is your single most important tool to determine procedure eligibility. My anesthetic of choice, the 4% lignocaine. This is, I put the pledget there for about 2 or 3 minutes. As you can see, the patient's eyes are moving all over the place. That's when I start the counseling and gently reassure the patient, followed by a superior rectus suture. As you can see, there's no pain at all. This is a topical phacomulsification with trabeculectomy. After the anesthesia is done, SR suture is put in. a trap flap is made. A cautery is done with a gentle irrigation of 4%. My preferred flap is the triangular flap. Then move on to the temporal side and perform the phaco, routine phaco. Nothing spectacular. It just has to be done a little quick. Then move back to the top. If I find this the conjunctiva is fine, I don't use MMC routinely. My trap punches are with the Kelly 2 punches wide. I sometimes put 3 sutures, 1 tight and 2 not so tight, or just a single tight one. It all depends on the clinical picture then. As you can see, it's pretty routine, and it's something that all of you all follow. Nothing spectacular. Mine is a phonics-based approach, so the atovicral has to be a little tight. I get a good bleb because I don't put a patch on top. So this was a study by Ike Emmett, one of the leading lights in glaucoma, a few years ago, where it was a randomized prospective study combining topical versus retrobulbar anesthesia in combined phacotrabeculectomy. He used the pain score analog with which 0 to 2 would be on the minimal pain score levels. As you can see, the graph is almost nil. The patients graded their experience based on their perception of tissue manipulation, touch, sensation, and microscope light, and during the surgery. This is vis-a-vis the surgeon's skills too. His results for the pain control was as efficacious as retrobulbar anesthesia, and both provided optimal operative conditions. Topical anesthesia is safer than retro anesthesia for combined phacotrap, as it eliminates many of the potential problems. This was his method, pretty similar to mine. This is one in which I've done a topical SICS along with trap. After the anesthesia, I did a temporal stab incision SICS.
Sir, request you to sum up, please.
Yeah, it's over. That's it. And yeah. Sorry. So, in conclusion, these are the advantages over subtenons, and patching is not required because there is less resistance to drainage. The advantages are the patient can respond more accurately, no use of anesthetics, and involuntary movement is minimized during the operation. There are disadvantages: a little pain during cautery, the need for supplemental anesthesia sometimes, and extraocular movements. So what is holding you back? It's a pretty good technique. Thank you.
Thank you so much.
Very good video, Dr. Braganza.
Thank you.
One thing, instead of using superior actus anchor suture, could you have used you have tried the conjunctival anchor, corneal anchor also?
I routinely do not use the corneal thing. in 2 of my cases, they cut through, and the patient had a little discomfort. You need to go more than 2/3 the distance of the cornea.
Other thing is for trap, we are using a long blade wire speculum which rotates the globe inferiorly. And usually I am not using any anchor suture.
Okay.
And except in some cases where the globe is tight or it is not rotating inferiorly. So 80 or 90% of cases we are doing without anchor sutures.
No,
could
I
you
do
try that?
that gives me an advantage. Now I have less movement when I have an anchor suture. So, and it's painless, so you might as well use it if you have the.
Sir, I have one question. How is your experience with the angle closure eyes with topical?
No, I absolutely don't do angle closure eyes. I put that in the indications.
Okay.
It's only primary open angle glaucoma.
Thank you, sir. Thank you so much. Now we move on to medical management and pediatric and pregnancy management by Dr. Basu. We are running short of time, so I request please sum up early.